Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Anna Popper. Today's episode is part of an ongoing series on addressing key challenges in the management of viral hepatitis. This series features conversations between a patient and a clinician where they discuss developments designed to improve access to treatment and care of patients with hepatitis. In this episode, Dr. Anna Cristina L Cruz of the University of Kentucky talks with Melody Cheng. Melody was diagnosed with hepatitis B in high school and talks here about beginning hepatitis B treatment during pregnancy. For more information about our guests and for a link to additional online education on this topic, please visit the link in the show notes. So let's turn it over to Melody and Tina.
Hi, this is Melody. I knew I have the hepatitis B since high school. So I know that there was from vertical transmission, but I do not have any treatment at all. I just regular follow up, and my energy was positive, but E energy is negative. So I have never been tested E positive yet, so that's a good thing. And my liver function is always in the normal range. So I had never taken any medication until like 10 years ago, I was pregnant. And then because I'm a Hep B carrier, so I discussed with my husband, and we don't want to have any chance to transmit to my baby. So we talked with my ID doctor and then discussion with him. So we decide to take medication, which is TDF. He said the transmission rate was very low, but in our situation, we really don't want to take any chance to have the transmission to my baby. So as I discussed with my husband, so we decided to take the medication since then. And now I am taking TAF for the treatment since then. So already like 10 years already. And I have a regular checkup with my abdominal ultrasound and the viral load. And right now the viral load is not detected, but I continue to use the medication. So I was wondering, is that the right decision during the time? Because once I take the medication, I have to take it maybe for life.
Typically, patients who do get pregnant get monitored during their pregnancy in terms of their viral load, their liver enzymes, and around 28 to 32 weeks is the optimum, the time when patients do get treatment if the viral load is more than 200,000. Mm-hmm. So that's the typical recommendation of the American Society for Association of Liver Diseases to start treatment if the viral load does go up to more than 200,000, because that's the viral load that has been shown to increase the risk of perinatal hepatitis B transmission. And then it is recommended to monitor, continue it for shortly, like after delivery, and then recheck in a couple months after the delivery for flares, because after delivery, there can be a flare of the hepatitis B. In addition, the recommendations is also to give the baby hepatitis B vaccine and immunoglobulin. Was your baby given both?
Mm-hmm. Yes.
Yeah. Of course, that's with patients who are carriers or not immune active. So immune active means that patients are not carriers, meaning they have elevated liver enzymes. And for E antigen negative patients, it's elevated liver enzymes more than 2 times the upper limit of normal and DNA more than 2,000. Of course, if they meet, or if it's E antigen positive, it's elevated liver enzymes plus DNA more than 20,000. So patients who do meet that criteria for being immune active, they do recommend treatment all throughout And of course, those who do not meet the criteria do get treatment greater than 200,000. So those are just the things that is typically recommended. Sometimes patients might be in the gray zone. They may not fully meet the criteria for being a carrier. Sometimes, we do recommend some certain tests like quantitative surface antigen to check if patients are real carriers or if they're actually immune active hepatitis B, if the liver enzyme does go up to more than 2,000. Sometimes that is helpful to know if patients are real carrier. It's hard to know if you were an immune active hepatitis B e antigen or if it was a flare related to like postpartum. Sometimes that, the cortisol level after in the postpartum kind of raises and that can cause like flares sometimes. So, but it's completely hard to know if that what happened exactly, if it was a postpartum flare or if you're a real immune active e antigen patient, not a carrier. So, but the fact that you flared greater than 1,000, it was reasonable to resume the tenofovir. Tenofovir alafenamide, we have limited data during pregnancy, but of course, the most data was TDF, and there's a lot of good data for TDF or tenofovir disoproxil fumarate, and that's a recommended treatment because of good data and available data and like the potency of the drug to decrease the viral load.
Once you take medication, you have to take forever. There's very low chance to get rid of the hepatitis B. So once you have the medication, you have to use it. That's why I try to stop after giving the birth, but it go flare, right? I have to use it. I don't want to take the chance, so I just take it every day.
Yeah. And I think that's what in other non-pregnancy situations, that's also the case. Some patients do try to stop, but of course, if they flare, it's reasonable to keep it indefinitely because you did flare off treatment. I think also one factor that may also play a role that we use in like determining if you need indefinite treatment or not is the degree of fibrosis. So one potential method or tool is to also know the level of fibrosis. So we have a lot of non-invasive tests called FibroScan. And if our patient does have cirrhosis or significant fibrosis, we also can take that in consideration to continue treatment indefinitely. We also take in consideration the family history of liver cancer, so that we also, even though like things may not meet treatment criteria based on the ALT and the DNA, we also consider family history and consider that to start treatment.
Mm-hmm. I do have family history though.
Of cancer, liver cancer?
Yeah, my father.
And you get ultrasounds every 6 months as well?
Every 3 months.
Is it okay if I ask your age? Because we also consider the age in Asian
50.
women. Huh?
Yeah, 54 now.
50. So one of the guidelines also is to start liver cancer screening in Asian women 50 or and above.
Oh, okay.
I typically do ultrasounds and alpha-fetoprotein every 6 months for regular liver cancer screening. I do have patients that, do get concerned about preventing transmission. And I don't have too many hepatitis B patients who do get pregnant, but the ones that do get pregnant, I have used guidance from the AASLD to treat or not to treat, but because they did not meet the viral load criteria, we did not treat. And we mainly really pushed really very close monitoring during all the trimesters during pregnancy. I was seeing them more frequently, and I was monitoring their liver function tests more closely during pregnancy and after pregnancy, and also made sure that their baby was vaccinated with both HBV and the vaccine. And other questions I have also from other patients is breastfeeding and the mode of delivery. And invasive procedures or like amniocentesis that were also mentioned on the guidelines. And it is safe to breastfeed during pregnancy or even take the medication while breastfeeding. Although there's not limited data, but it is suggested that it can be given during breastfeeding. And patients do not have to have cesarean section to prevent like hepatitis B transmission. And then they're just recommending that in patients who do have a high viral load to take the amniocentesis in consideration in terms of the risk of transmission, because there might be a potential risk.
Thank you, Melody and Tina, for sharing that conversation with us, and thank you for listening. Look out for more episodes in this series at clinicaloptions.com/hepatitis.